Welcome to our Mary Grilly Primetime Alive presentation, Update in Colorectal Screening 2025. I'm Vicki Newell with the Primetime Alive program at Mary Grilly Medical Center. As a reminder, if you'd like more information about Primetime Alive or to sign up, you can go to our website, mgmc.org/PTA. Our presenter today is Dr. Larry Johnston. Dr. Johnston received his Bachelor of Science from Mount Mercy University in Cedar Rapids, his Master of Science and Doctor of Osteopathic Medicine from Oklahoma State University College of Osteopathic Medicine in Tulsa, Oklahoma. And he also completed a residency in internal medicine at Oklahoma State University College of Osteopathic Medicine. Dr. Johnston joined McFarland Clinic's Gastroenterology Department in August of 2022. Please welcome Dr. Johnston.
And I did fellowship in Tulsa as well, so that's how I'm a gastroenterologist. I'm training up in trauma, so that's okay, but yes.
Is your microphone on?
Yeah. All right, so
There we go.
Dr. Johnston, like she said, and nice to meet everybody. Thanks for coming. Appreciate it. And I was asked to give kind of updates on colorectal cancer screenings as it pertains to kind of what's available now and what we're going to be talking about throughout the rest of the talk of how you screen, why you should screen, why is it important to be preventative in your healthcare as a whole, but that's what pertains to colorectal cancer. So, like I said, kind of my talk will go kind of through some of these talking points of epidemiology, and what that basically means is why is this important to us and why is it important to every American, and we'll get into those details in a second. What are potential risk factors that increase your risk of colorectal cancer? What are maybe some potential protective factors that we can do to help just on our own? And that's, well, of course, screening is a predominant way to reduce your risk of colorectal cancer in your lifetime, but we'll talk way more about that, about what screening tests are available, with how that data looks comparing to each other, and why would you maybe want to choose one or the other. And of course, a bit in the weeds about why does colon cancer develop in your body and how we can maybe prevent it and those kinds of things. And then further management beyond positive tests, and then where are we going in the future, what's currently available, what will be available in the next couple of years and beyond. So March is actually Colorectal Cancer Awareness Month, so it's kind of timely that we're doing it in March, and that is that blue ribbon. And why we do this and why we have a month is because it is still the second most common cancer in the U.S. in adults. It is the third leading cancer death in America still. That means that most people have a 1 in 23 or 1 in 25, depending if you're male or female. So in your lifetime, you have about a 4 to 7% chance of colon cancer. That's too high, right? We can't prevent that. That is just living in our life, living in our Western lifestyle, doing what you do normally. That's at a baseline. And then we'll talk later about risk factors that might increase that risk above that baseline. So with those numbers, we are seeing around 107,000 colorectal cancers per year, about 46% additional are just rectal cancers. We do treat colon cancer and rectal cancer a little bit different when it comes to management, so that's why you see two different numbers, because we kind of look at those, we see prognosis and diagnosis and things based on each one of those, almost like it's a separate organ, separate cancer itself. And that's every year, and over 53,000 people die from colon cancer every year. And colon cancer is preventable, and we'll talk more about that. So, as we have increased screening for colorectal cancer, with knowledge that we all have that risk in America, we have seen a reduction, and I'm sorry that this is kind of maybe small on some of the screens, but looking at the very top dotted line, that's ages of 75 to 84 in a life cohort study, looking from 1999 all the way to 2019. As you see, at start, it was anywhere from about 145 to 150 patients with deaths from colorectal cancer in 100,000 people. As we go down from 1999 down to 2019, it is closer to now under about 90, 85 to 90. So we've had a marked reduction in that population by screening. We'll talk more of how we can do better, because that's still not good enough if you really look at the data. And as we go down younger age groups, same thing, we're reducing it from 80 down to 50, and then 40 down to maybe 30. And that bottom line is the younger population, that's 40, so under 50, 45 to 55. And that looks pretty flat, but I'll show you this graph. Sorry. Yep. this graph here, and you see that younger cohort actually has had an increase in the last couple of years. It's about a 45% increase in their population risk of colon cancer. So like I kind of told you earlier, it's about a 4 to 7% maybe in your guys' cohort. In my cohort with my age, it's probably projected to be closer to 10 to 15%. We don't have all the answers for that yet, and we'll talk a little bit more about that. So, like I was saying, incidence of younger, being at people under the age of 50, they make up 10.5% of new cancer diagnoses in America. And that is about a 50% increase since 1992. Why that is various factors, and we'll get into that when we get into the potential risk factors. So what increases your risk from just baseline? Age, obviously, if you looked at those numbers. Right? We were looking in the 150 to 200 people per 100,000. If you look in the younger cohort, it starts around 12, 15. So obviously age is one. If you have a first degree relative that had colorectal cancer, there's maybe a genetic component, so that increases your risk. If you have multiple family members with even precancerous polyps, that increases your risk. And then of course we know of genetic colon cancer syndromes, which only make up about 15% of all colon cancers that we diagnose. And those come from these genetic disorders that you see on the screen, adenomatous polyposis syndrome, which are genetic factors where you don't repair your DNA like you should. And so it increases your risk of having bad tumors. And they don't just happen in the colon, they happen in multiple organ systems because of that. Same thing with Lynch syndrome. And then even there's one that's called juvenile polyposis syndrome, which is more seen in kids but can advance into adulthood now that we see we've had better treatments. We are getting more data on breast cancer and ovarian cancer with cancer treatment and studies. So when people get these diseases now, they actually run these various panels that look at all these different genetic markers or changes that are on those organs or those cancers. And now we're seeing that some of those correlate to colorectal cancer. So even in my 3 years here at McFarland and my 7 years of training or like all my time in GI, there have been more and more of these cancer markers that are getting referred by oncology because they had breast cancer, but then they did their panel. Hey, this has been shown to have increased risk of colon cancer. They need to be screened in a different protocol than what an average risk person is. So there's a lot more data coming out from these genetic forms and as we get more information. And so that is a picture of people that have adenomatous polyposis syndrome. As you can see, they've got thousands, if not millions of polyps. And so that increases the risk of colon cancer because those are the things that then would grow into cancer. So you can't surveil those people. They unfortunately need their colons cut out at a very, very young age to reduce their risk of colon cancer because it's close to 95%. Other risk factors are people that have inflammatory bowel disease, mainly ulcerative colitis. After they've had their disease for 8 years, they are at a higher risk of colorectal cancer in their lifetime. And there's some evidence that people that have had prior abdominal pelvic radiation from the scarring of the radiation, the fibrosis, there is increased risk of colon cancer, but it's kind of more of a question than the other ones I've already talked about. These are kind of why we maybe see people in younger ages having increased risk, and that is that these don't increase your surveillance. We don't tell you that you should have more colonoscopies more often because of these factors, but if you look at any of the population-based studies or observation studies, there has been shown kind of an increased odds ratio or more likelihood that you could get either colon polyps or colon cancer. So the obesity epidemic is a big problem. With the obesity epidemic comes diabetes and insulin resistance. Also the Western diet, like I talked about earlier, which is again processed more than other cultures, as well as we eat more red meat than tofu or chicken and fish, Mediterranean type foods. And that has been shown, of course, alcohol and tobacco use, and then physical inactivity or sedentary lifestyles, us being more at computers, sitting around, not being as laborious as we used to be, has also increased potentially risk of those. So that's maybe why we're seeing the younger cohort, because they were in the thick of this from their start, where you guys in your cohort maybe are catching it towards the end of your life cycle. And just time is really what's causing this increase. So kind of the things that are opposite of the list I just talked to you about are the ones that can maybe protect you. There's no data or enough evidence to say that we should recommend people getting exercise for colorectal cancer as a whole, but it is there for all the other things, for cardiovascular disease, for high cholesterol, high diabetes control, right? Weight control. All these things are there just for your overall health. That's regular activity. The more Mediterranean type diet or soluble fiber up to 20 to 30 grams per day. We don't see hardly any colon cancer in Africa or other places that have high fiber diets. We see it predominantly in Western cultures because we are a low fiber diet place. So they push upwards of 40 to 50 grams per day as their baseline. That's what they just kind of eat. It'd be a lot of fiber for us to eat 30 in our day if you look at our food sources. And then it's soluble fiber, not insoluble fiber. Soluble fiber. There's been some evidence that aspirin has been shown to help prevent the cause or more polyps from being formed. It can be used in those people with genetic causes, those FAP or the adenomatous polyposis. It's used for some of those people to kind of extend their life cycle of their colon before it comes out. But there's not enough evidence to say that everybody should be on aspirin just to prevent colon cancer. And even that comes into cardiovascular studies where they say maybe you don't need to be on it for various reasons and just because of the risk of the medicines. And of course, then other things that are observationally been kind of correlated to reducing your risk is increased vitamin B6, calcium, and vitamin D. So here we get to kind of in the weeds a little bit, but this is the pathophysiology of what happens with the most common type of colon cancer, and that can be an adenocarcinoma or cancer of the glands of the colon. So these are these precancerous polyps that kind of go through this life cycle to get to colon cancer. So you see these changes in the crypts. You turn over your GI tract, it's about as fast as you turn over your skin. This is kind of a crazy concept, but your GI tract is a tube like your skin. You eat food, that food stays inside you, you absorb the nutrition, but all that vegetable matter or things we can't break down stay in you, and that becomes your waste. Okay? But because of that, it's an environment inviting and interacting with a lot of bacteria and viruses, the outside world basically. So you turn it over very rapidly, and it starts at the very base of that thing. You can see here, this is where you have stem cells, and these things will just kind of populate, and they'll go up this kind of chain here. And as they go and they mature and if you get a mutation or an alteration, that stays. And then when you get that second hit is when you get two hits, you start to get these kind of tumor initiating cells, and that makes this kind of pre-cancerous polyp, which we call a tubular adenoma. And that's what me as a gastroenterologist doing colonoscopy is looking for, trying to catch those things at that stage so they don't keep growing to a late adenoma, advanced adenoma, colon cancer, or even, heaven forbid, metastatic disease that's spread throughout your body. So this is the predominant pathway of colon cancer. It accounts for anywhere from 70 to 75% of all colon cancers. Go back. And this is the one that takes anywhere from about 7 to 10 years. So that's why when we get to our surveillance protocols of when you get your next colonoscopy, it's based off of this typical pathway. We are seeing an uptick in this kind of pathway of colon cancer. This is called a serrated pathway. So this is not that traditional crypt going up to an adenoma, then going up the adenoma pathway. This is a completely separate pathway that really goes from the crypt, mutation, and then it goes. So it is faster growing, typically anywhere from 2 to 5 years, and these polyps look different endoscopically, they look different morphologically, and they are typically more on the right side of your colon typically than on your left side of your colon. So, but we're seeing more of these, and so that's why we're seeing a little bit more uptick in younger people because of this pathway. We've seen an uptick in right-sided colon cancers because of this pathway as well. Any questions about that? That's just more there for your FYI to be complete. Okay, so we've kind of talked some bad news about why people are increasing other risks, but really what's not good is that we only screen about 66% of the population that could have a colonoscopy. So that data I showed you where we're improving, death rates are dropping, we could do markedly better if we could get closer to 80, 85%. High quality colonoscopies or screening like that can reduce colon cancer by anywhere from 20 to 40% depending on the individual endoscopist. And colon cancer is preventable and survivable if we detect it early. So just screen the right populations early enough, hopefully you can prevent it gets to that late stage. And since this month is Colon Cancer Awareness Month, there was a study done by this group, which is the Colon Cancer Alliance. They basically give information and go out and try to get people to get screened and talk more about it, kind of doing stuff like this. But they did a survey of 1,000 people, and it was published in the USA Today. And of those people, 51% said they would rather do household chores than do colon cancer screening. 69% of those people said, I'd rather file my taxes than do colon cancer screening. 57% of them did not know that colon cancer is preventable through the removal of those precancerous polyps that I kind of showed you on the adenomas pathway. If they knew that fact, 98% said they would screen. About 57% at the end of their survey said that they would likely get screened in the next 1 or 2 years. So their overall attitude said, no, I don't want to do it, but then they kind of said, no, I will. So we can do better, and we're trying to do better. But we only can do better if we screen, and that takes participation from others, which are you guys. Okay, so because of the data that I showed you earlier, why do we screen and when do we start screening? Well, we start screening at age 45. So that's happened about 5 years ago. Because of the uptick that we've seen in that younger population, all GI societies have gone from 50 down to 45. So it's all 45. There are some cohorts, African Americans, Native Americans, they were at higher risk. They were doing it at 45 when other average risk were 50, but we have all gone down to 45. Of course, if you have a first-degree relative, you got to do it 10 years before they were diagnosed. If Dad had colon cancer at 55, you should start at 45. If you're younger, you even do 10 years before. And like I said earlier, people with inflammatory bowel disease, which is ulcerative colitis or Crohn's colitis, they are higher risk. So we start screening them for colon cancer, not the disease of their colon, for colon cancer alone at 8 years. And they're at a higher risk, and they come back every 1 to 3 years. So how do we screen? Well, there are a litany of things that can help us start screening for colorectal cancer. The ones that I do are obviously colonoscopy. So that's that little box right there. We have stool-based tests, which are card-based tests like that FIT or fecal immunochemical test. We have a fecal occult test. We've got a stool-based test that looks at altered DNA. There's a new test that got approved it looks at altered RNA. So these are products that the colon cancer or colon polyps produce, and it gets picked up in your stool. We can do a limited colonoscopy or a sigmoidoscopy. And then there's even a CT or a virtual colonoscopy. This is kind of how we use and what we think we should do each one of these screening tests and why. And the reason is that all these tests aren't kind of made the same, right? The production that goes into a colonoscopy is markedly different than collecting a stool sample at home or a CT scan, right? So test availability, the preparation, the cost, the privacy, all these things go into the factors of who does what testing or if they do testing at all. So we consider all of these factors when we talk to patients about what's best for you, what do you want to do, what's best for your lifestyle, what are you willing to do, so we can be helpful. So trying to break down those walls and barriers of, let's say, people not wanting to get colon cancer screening. That should be the least of their priorities. They should want to do it. We should be able to be helpful and do it in any way, shape, or form that is best for them. But not all screening tests are made the same. This is kind of data that, I don't know who's a statistics person, but so sensitivity means that how many people can you screen, and then they are going to be positive when they have that test. And then more specificity, which is the other things of colon cancer and adenoma, is really more on if that test is positive, how likely are we to find that result, okay? So when it comes to screening tests, you want a high sensitivity, you don't really care that much of specificity because you want to catch everybody in the window that you think might have it. You don't want to miss somebody that does have it, okay? And so the higher the number, the better the test. If you look at colonoscopy, it goes anywhere, depending on the person, from 86 to 88, and then flex SIGs is 87, colonography is 88, FIT test is pretty good at 92, 91, 94, and then the fecal occult tests are 92, and then the DNA tests are in the 86 ranges. So that's just for polyps. Then you look at big polyps and then colon cancer. Obviously for colonoscopy, it jumps up to 95 to 99 ranges, and then the other ones kind of drop off because they're not as good as looking for advanced polyps. So all those things kind of come into your decision of what test you should do to help you know what's best for you in your screening and your risk and what you're willing to do. Because like for the Cologuard, the multi-targeted stool antigen test, which is that lower bottom column, they are 91% for colon cancer. I can tell you I have never missed a colon cancer. They miss 8%. Right? So that's kind of the different data. So what helps me as a gastroenterologist are my GI Society guidelines and the task forces and people who put the research into this. They look at all the data. And back in 2020, all three societies kind of said, hey, we need to look at these tests that are available, and we got to figure out kind of how to tier them so we can make those recommendations easier, more digestible for you. So what they came up with is tier 1, meaning the best evidence, the best things we should do, which is colonoscopies, or annual FIT test, which is stool-based testing, or they asked me to do a survey, sorry. Okay. Or then.
Oh. I don't know what just happened. The fortunate thing is they all have the handouts. Yeah.
We can keep talking. I got it in front of me. If you guys can see it. Online might not though.
I'm gonna turn the power off for 1 second. Turn it back on. See if that does it. I know they've had a few, and it's still, is it still all the way in there?
Mm-hmm.
Let's try. He's got a concert going on back behind him here. There. All right. Yay, Vicky.
Thank you. Okay, like I was saying, so tier 1 means that it's highest recommendation, that's what we recommend for most of our patients, the majority of the time, is tier 1 tests, colonoscopies, or annual FIT tests. If you're not willing to do a tier 1 test, then it's the next best test are going to be that flexible sigmoidoscopy, which is a limited colonoscopy, a virtual colonoscopy, or a CT colonography, or that stool DNA test, which is commercially known as Cologuard.
Okay.
All right, so now we're going to talk about each individual screening test. So colonoscopy, since it was the tier 1 test, it has the longest interval of protection, meaning if you have a high quality endoscopy with no polyps, it is 10 years. If you have a negative FIT test, you do it next year because it's every year. If you have a negative Cologuard test, it's every 3 years, so if it's negative, you do it in 3 years. It's the gold standard. It's unmatched when you look at the polyp detection in cancers, like I showed you on their screens, right? 90-95%. It is the only strategy that provides protection because of colon cancer and reduction, is because we remove those precancerous polyps that then later turn into cancer. But there is a caveat, they are endoscopic or the proceduralist dependent. So not everybody that does colonoscopy is the best endoscopist. I'm just going to be honest with you on that. So this is how we do colonoscopies. And how many share of hands of who's had a colonoscopy before? Good job, guys. And if you didn't do it, that's okay too. I'm not gonna. It's your prerogative. That's why I'm here. So, but what entails a high quality endoscopy is we have quality metrics. I am held to a standard that I need to track this data for you guys to know that I'm doing what I should be doing for you to prevent the problems we see with colonoscopies. So cecal intubation, which means getting all the way to your colon, all the way across your colon. This is your cecum here, this blind pouch where your appendix grows off of, and it meets up to your small bowel right there. We look at the right colon twice, and that's because of that striated pathway that I told you about. These polyps are flatter, they're harder to see, and they live on the right side. So we actually go up and down that part of your colon twice on purpose, looking for these specific kind of lesions. And of course, we look at your whole colon. We spend time doing that, going in between all the folds and looking for these polyps because they grow anywhere on the lining. And that has to be anywhere over 7 minutes. There is a potential change, it'll be over 8 minutes because there's a time curve of how long you look and how well you detect. There's kind of a perfect match. And they're kind of shifting it to a little bit longer looking. How's that work in clinical practice is a whole different story. Because we all have 30 minutes to do colonoscopies. We got to do lots of colonoscopies to get them done so we can treat more patients. So there's kind of a production curve too, but that's neither here nor there. The most important part from you guys' standpoint is your prep. You guys doing the prep, doing the best you can with the prep. Because that is part of the parameters. If it wasn't a good prep and I missed something, you can't wait 10 years. You got to come back quicker because we have to have a good exam. You need to do all of these things to be what's called a high quality exam and then use those guidelines of intervals. So if you had a bad prep, but I do all the other stuff, you can't come back in 10 years. You got to come back sooner. we did not do a high quality exam. And then of course, where I say it's endoscopic or procedural dependent is what's called an adenoma detection rate. So it means we track how many adenomas, those precancerous polyps I find in our population, and I track it throughout the year, and I know what my number is. And we have goals, and the goal is anywhere from 25% in females, 30% in males, for a goal of 25 overall, or 35 overall, excuse me. So this is what colonoscopies can do. So when you go in there and you look, you'll see a normal colon, that's all those folds. Or we see polyps, which is this little kind of bump or growth here. And then we actually have maneuvers, snares, and other things through our scope that we can take those things and remove them, retrieve them, and get them checked by pathology. See if there's any high-risk features, how big it is, all those factors kind of dictate when your next colonoscopy would be. So I'm going to stress on the bowel prep because you guys are the ones that do it. But so comparing those colons, the one on the left is what we call, we grade it from a 0, means it's unprepped, like you didn't take any bowel prep and there's solid stool in there, to a 3. So the one on the right's a 3, meaning it's pristine, there's nothing. And we grade this after we try to clean. So on that left one, I would try to clean that the best I can to get a good look, because you did all the time of taking off work, changing your diet, drinking the prep, you did the best you could. I got to add on and do the best I can to help you. But sometimes you can't, because our GI juices are kind of sticky like wallpaper. And I can't have enough water to spray that off under pressure. It won't come off. So that's why the bowel prep is so important, because it actually gets all that removed. But we need that exam on the right to be a high quality exam. The one on the left, you'd have to come back at a sooner date than you should, even if you didn't have any polyps, because I can tell you I could maybe miss 60% of your colon with that. You know, I can't do a good exam looking at small polyps, things that are small like that. So endoscopically, this is kind of that same slide I showed you graphically of the different changes or progression of adenocarcinoma, or the adenomas pathway. So that one on the left, this is just a precancerous polyp, so the first stage. This one here is larger, has high-risk features. This is probably what's called a tubulovillous adenoma, which means it's further stepwise or up the ladder towards colon cancer. And then this over here is actually a colon cancer. Endoscopically, we only see the lining, so when we see those bumps or growths, I can't tell you if that thing has grown through the wall or even further, so we have to do other images, but it can. So colon, stage 1 stays in the colon alone, 2 goes through the wall, 3 goes all the way through the wall, and then 4 goes through the wall and it's spread to other organs or to the lymph nodes. So we want to catch stuff way back over here. By screening at the right time, we are more likely to catch it on that side of that scale. So that picture on the left is an adenoma. That's what they look like under a special light that kind of looks at the pits. On the right is more of a serrated pathway polyp. So that's this thing here. It's kind of hard to see because it looks just like the lining, but that's what that is right there. So that's what we're looking for, and that's what we're tracking, is how many of these polyps we find per colonoscopy. There's a polyp on that screen. You might not believe me, but there is. Anybody guess where it's at? I can see that halfway decent. The light doesn't help, but here, I'll show you. So it's right there, and actually that blue, so that black circle is the polyp. That blue circle is actually high risk. It has high-grade dysplasia, which means it's tiptoeing towards cancer. It's right at the edge. So that's a serrated polyp right there. So like I said, it is operator dependent. So if you have a low ADR doctor, then you have a higher risk of colon cancer. Those numbers say that if you're under 11, so they get 11% of their patients they can find polyps in, you have an odds ratio of close to 11% X, higher risk of colon cancer than someone that didn't. 10, 12%. So this is my data. Like I said, I track this. So I get into the cecum greater than 95% of the time, even if I do a complete colonoscopy from start to finish. I average anywhere from 8 to 9 minutes on withdrawal. It depends on the patient and what's going on. My adenoma direction rate's currently was 44% for this year so far. Last year was closer to 50%. And then my serrated pathway one is around 6. Not to toot my horn, just to tell you we should be checked, and you should check us to get to everybody else. That's what means we're doing a good job. All right, enough with colonoscopy. So let's say you don't want to do that, but you want to do other tests. So this is an available test called fecal immunochemistry, or FIT testing. It is a stool-based test that looks at blood in your stool, human blood. Can have a false positive with like beets and some other stuff, but not that common. It assumes that colorectal cancers bleed, and we're picking up in your stool. You have to collect at 3 separate bowel movements, so it's a ×3 test every year to help us increase our kind of screening numbers. It has to be done every year, and of course, if it's a positive test, it's screening, you need a diagnostic test, which is a colonoscopy. Advantages are it's at home, so there's no change in your lifestyle. You just do it when you want to and turn it in, you mail it back. They are low cost, but they are very good, and they are used quite heavily in managed care systems like Kaiser Permanente out in California, the VA system, Indian Health Services. If you look at the European colon cancer screening, their numbers are kind of between us and Africa and Asia. They are predominantly a fit-based testing, and that's because they don't have enough endoscopists to do them. We're more of endoscopy heavy in the Western societies, but they are not. So it doesn't mean it's not a good test. It's widely used and does well. Does have disadvantages. It's good, but not great for colon cancer, right? Like we just looked at those numbers. And it only really prevents colon cancer when you pair it with a colonoscopy. So if it was negative, and then we do a colonoscopy, you might have colon cancer and missed it in between. So we've had this out for 7 years now. So this is a multi-targeted stool DNA test, again, commercially known as Cologuard. And what it looks like is it does a fit test, so that blood test on your stool, as well as looks at those markers, which are genetic markers made by colon cancer or advanced polyps. Advanced polyps, again, are bigger than 10 millimeters or 1 centimeter. And they look at those markers, the KRAS, the actin, and they look at that and they test it. When they report that back to us, if your doctor orders this test, it says only positive. It does not tell us if your fit was positive or the DNA was positive. It's just positive. Because both those tests are screening for colon cancer, and if they're positive, you need the next test, which again is a colonoscopy. It is a single bowel movement. You collect it once, and you just ship it off back to them. Advantages, again, is at home. It's not invasive. It's highly sensitive for colon cancer at 92%, but I would argue for colon cancer, it should be higher than that, because that means 8% of people with colon cancer have a negative test. You repeat it every 3 years, which has an advantage over fit testing every year. Again, low sensitivity for polyps, specifically serrated polyps. It's expensive. It's more expensive than fit testing. And the current model out there, or current version, has a fairly high false positive rate of close to 12 to 15%, to the point where the FDA said that's too high, and they are making a second version that should be commercially available this year, with the purpose of getting that number to go down. So what that means is that you had a Cologuard, it was positive, you had then a colonoscopy afterwards, and there was nothing in your colon that met that positivity. No advanced adenomas, no colon cancers, and that causes a lot of angst for patients, right? You screen positive, you told me I might have colon cancer. You don't get your colonoscopy for 2 months, and we find out it was completely normal. So we got to get that number down to help with some of those kind of screening issues that we talked about. Watch the slides over about angst and availability, right? So what's going on in the future? And so, like I said, Cologuard 2 is coming out this summer. There's another company that does the same thing, but it looks at RNA, and so their numbers are similar, but maybe a little bit better. And that's called Colosense. Same thing. It's a single bowel movement that gets shipped back to the company. This spring, there was a test for DNA on your blood, so it's a blood sample, and it can screen for colon cancer. It's available. And then on our end, being for endoscopy, how we're getting better and trying to bring all endoscopists onto the same kind of platform and quality is this thing called a computer-aided detection system. So you guys probably hear about AI, right? Okay.
Those expensive tests?
So the Cologuard is fairly expensive. Colosense will be the blood test. I haven't seen it used enough yet to know what the cost is. And then the CAD testing is something that goes onto our colonoscopy tower, and it is a fee for it. And how we kind of pay for it is the more polyps you find, you bill more, and it's the whole thing. But yes, it does cost a little bit more than normal testing. But as they get widely, so that was that's the Colosense test there. Looks very much like the Cologuard test. As these things are more available, insurances will cover it, and almost all these are covered because they are preventative screening, right? So you should have zero out of pocket. This is that computer-aided detection system. So I showed you kind of polyps before, just normal. Well, this is a little bounding box that we would see on the screen, and it would show us flat lesions or think it is. That lesion is there on the left, you don't really see it very well in the image itself. And then the top one you saw one kind of in the far field. So it kind of helps people know, hey, look at this area closer. Doesn't actually help us diagnose what that is, but it's just more there to be identifiable. The next stage of it is a diagnosis. So you could look at that thing, you'd get close, you'd give it the parameters to the computer. They would then go, if that looks like it's a tubular adenoma, you should take it out. That one looks like it's hyperplastic, which is completely benign, can stay in your colon forever and never be an issue. So you don't have to take that out, risk of bleeding or perforation by us taking it out endoscopically. So that means as we keep things, we reduce your risk procedurally, but we take the things we really want to do, take them out when we want to, or even increase the things we should be finding and take them out when we find them. So, in summary, again, colon cancer is the second most common cancer in U.S. adults. So we need to keep doing what we're doing and be better at it. It is preventable, but going through a screening and surveillance protocol and guidelines. No screening test is definitely better, or any screening test that I mentioned and talked about that's available is better than not screening at all. So I recommend talking with your doctor about what's the best option for you. Any questions?
At what age do they quit doing colonoscopies and why?
Sure. So the question was, when do you stop screening or doing surveillance for colon cancer, and why would you stop? So the current guidelines are that at age 75, you have a conversation with your doctor of risk, benefits, and alternatives to continue colon cancer screening. The reason we stop is the risk of the procedure can be harmful when you have kidney disease or other health problems, going under anesthesia, going through a bowel prep, which can dehydrate you. So if you've got kidney problems, electrolyte problems. So it's not really the best thing to do to put you through that risk if it doesn't really give you benefit. If you have that many comorbidities and your life expectancy is less than 10 years. So the caveat to that is, do we stop? No. I have done colonoscopies in people in their 80s. But they also have family members that live to be in their hundreds, and they are healthy and they want to continue screening. All screening tests are available at every age, except for the FIT tests, the Cologuards. If you've ever made polyps, you can read the commercial, right? If you've had colon cancer, your family had colon cancer, or you've had polyps, you should not do these tests, which is true. If you have had polyps, colonoscopy is the only surveillance test that's FDA approved. Everything else is only for screening, okay? Checking you the first time or continue to screen you.
I have a question.
Sure.
You talk about fiber and increasing fiber, and I know getting it through your diet is the best.
Sure.
Thoughts about something like Metamucil?
Mm-hmm. Completely fine. So yes, it doesn't matter if it's a fiber gummy, if it's Citrusel, Metamucil, you eat an apple. Don't care. If you can't eat fiber because you don't like fruits and vegetables, that's fine. You can do Metamucil, Citrusel, anything else that comes that way, because those are soluble fiber. There is I don't use it, so I don't know the name off the top of my head, but there is one that uses inulin, which is IMUL. That is an insoluble fiber. Do not recommend it. But any other source of fiber that you get soluble.
And is that like a once a day thing? I mean, do you, okay.
Typically it's once a day, because what you're going to do is you're going to eat and drink other forms of fiber through your day. So you don't supplement all 20 grams in a tablet or Metamucil or gummies or however you want to get it. You eat your food and you'll get all that, and you just add that on. You got to do it slowly though. And I say that is fiber, when it gets into your GI tract, can make you irritable because your gut microbiome really likes it. It helps the bacteria do its job and symbiotically help you, but it can cause gas and bloating. So if you do it rapidly, like you go up from a zero fiber or low fiber diet to a high fiber diet, you will feel bad. But if you stay at that level of fiber for a couple of days, your body gets used to it, your gut microbiome kind of calms down, and you can continue. So you got to do it over a slow process.
Does diverticulosis increase your risk as well, and how does that play out?
Sure. Good question. The question is, does diverticulosis increase your risk of colon cancer? It does not. Those are actually the most common thing we see in a colonoscopy, starting about the age of 40, and every decade it's more and more common. What they are little pockets in your colon where your lining kind of pokes through. So as we're looking down that tube on a couple of those pictures, you would see a little pothole. They're little mini hernias. So it's where the wall is kind of poking through. So, but they do not increase your risk of colorectal cancer at all. No. And they don't change your surveillance. So if you had sigmoid diverticulosis, you don't need to have another colonoscopy at a different date or time besides of what your problems are.
I was just looking to see if we had any online.
Sure.
Yeah.
So,
Sure.
let's say just hypothetically, if you had colon cancer in surgery, and then a year later you have another colonoscopy, is it normal in that year for polyps to grow back like 5 centimeters or 1.5 centimeters?
So the question is, if you had a personal history of colon cancer, had surgery, had your then subsequent follow-up 1 year, what you're supposed to do, and on that exam you had large polyps, is that normal? Is that you're asking?
Yeah.
No.
Well, I know my next one was then due for 6 months, but maybe even 6 months is too long to wait.
No, so that's a good question. So
If those polyps are growing that fast, it just amazes me.
yeah, so that's the question is that typically some people can grow fast to the adenoma pathway. Not everybody does, right? Question is, was that something that was there that wasn't 2 centimeters or bigger? It was smaller and then it was missed and then it got bigger. That's the other question. So, but yeah, if you have large polyps, you come back at a much closer interval because they're more concerning, right? They're advanced. They're over 10 millimeters. Typically, you would go, if it was normal at your 1 year, you'd come back in 3 years, and then you go to 5 years, and you stay at 5 years because you're high risk. But because of that, you come back at a shorter interval because of the size. Yeah.
Okay, so my dad had a colonoscopy, no, he had a bag put on it when he was like 86.
Sure.
And he did fine, but, so then I had to start having them every 5 years.
Mm-hmm.
And so, since I'm 78, do I still have to keep doing them every 5 years since everything's been good? Or is that kind of between me and my doctor? And
Sure. So the question is that this is a personal question, except her experience, but father had a bag or a colostomy bag, I'm assuming?
Yeah.
Do we know it was from colon cancer or for
yeah,
some of
it was colon cancer.
Okay,
yeah.
so colon cancer, and then because of her dad had colon cancer, high risk, and you've been doing a high risk surveillance protocol your whole life till now?
Yeah.
So no, you don't. And I say that is because dad was at an advanced age, was probably something in dad and not genetically passed to you or your siblings.
That's what I thought maybe.
But because he had it at an age, that's why you got it at a younger age and you got 5 years. But once we get enough data in a row, it's a conversation with you because you are not a part of that guideline, right?
Yeah.
This is the practice of medicine.
So does that follow over then like to my children?
No,
So they have to,
no.
they can kind of assume they're,
Average risk.
yeah.
Correct. Yeah, first degree relative. First degree relative. None of our screening and surveillance colonoscopy guidelines use anybody outside of first degree relative.
Earlier in your talk, you talked about, or you downplayed red meat.
Yeah.
And yet red meat's a good source of protein, so what are we going to do?
So the question is, yeah, giving me crap about red meat. No, so yes, but the problem with red meat is though it causes a lot of other problems, right? So red meat's been associated with increased cardiovascular risk, obesity, because it's pro-inflammatory. We don't feed our cattle like we used to feed them, right? They get finished with corn and other things that cause fats in them that are pro-inflammatory. So that's kind of the reason. So yes, it is good protein, but so is dairy. So the products of yogurt, cheese, whey, tofu, soybean is very high in protein.
They don't taste good.
I hear you. You probably haven't cooked tofu the way that I'd to cook it. But I mean, there's a lot of other sources. Chicken, fish, right? I would even say that pork, sorry, I know we're in Iowa, but pork gets finished the same way. So it might be white, but it's treated more like red meat because it's finished with corn. Same reasoning. So no, it's not that, it's moderation. So I say that for sure. But when you eat nothing but meat and potatoes and no fiber, that's the problem, right? So it's the combination.
Okay, so it sounds like you've
have a different diet, I'm guessing going through doing years of the work that you do, would you share with us what your diet is?
Your diet.
I eat whatever I want. No, so I mean, I know this data, I mean, I have this, but I mean, it's moderation, and I do that. I'm not a plant-based, I wouldn't tell anybody else to be plant-based. I would say Mediterranean has the best data, so I eat more of a Mediterranean diet. But did I have 2 cookies today? I did. Yeah, I'm just gonna be honest, so. Because that's the thing is, the diet that you eat is the one that you're willing to do. If you're not willing to do it, it doesn't help anybody. Those are fad diets, right? And that's when we see your weight it comes right back. You are miserable. We get quality of life from what we eat and how we do it. It's a part of, we're social animals, it's a social construct in the United States. So, moderation, but I would say the biggest thing is fruits and vegetables. There's a study that was put out a long time ago, 1 in 8, right? You've probably seen these things, like only 1 in 8 Americans eat the servings of fruits and vegetables in a day. They redid that study, it has gotten worse. It's 1 in 10. So we can just do better by eating more fruits and vegetables.
So inflammatory bowel disease, increased risk for patients that have that, children, do they need to screen sooner?
So the question is people with inflammatory bowel disease that are higher risk for colon cancer due to their kids or offspring need to be screened at a different time? They do not. They are not higher risk. So that's an individual risk. And Crohn's has to be 2/3 of their colon has to be involved to be increased risk. So Crohn's and Crohn's colitis. Crohn's typically happens in the small bowel, and that does not increase risk of colon cancer. And that's why ulcerative colitis is more common, because it only happens in the colon. That's a whole other talk, but they only get it in their colon. So they are at higher risk because it's a predominant colon organ problem, so. Yeah.
Is there a point where, at an age, that the insurance would not pay for a colonoscopy?
Question? Sure. Question was, do you age out or insurance ages out paying for your screening exam? They do not. One thing I forgot to talk about, so we talk about the FIT tests and the Cologuards that are positive, the colonoscopy. Previously, 2 years ago, they passed this. So before it was, if you had that test, you paid for a diagnostic colonoscopy. That was not a screening test, you paid a copay. It's like getting a CT scan or an X-ray or an MRI. As of 2 years ago, they passed it and said that's a continuation of the test. So if you had a positive FIT test or Cologuard, your subsequent colonoscopy is all under that one guise and is covered. That's recent, but that was a change. And we pushed for that because people would not get their colonoscopies because they didn't want to pay their copay. We don't have no reason to do that. It's all about the screening test. We want to be preventative.
Touch the screen.
Oh, sure.
Time it out there. I know there we go.
So you had shared your data on
Yes.
detection rate. Is that information generally available for any gastroenterologist?
So the question was about the quality indicators and the data. It is not readily available. I do not publish it anywhere. We are working on maybe putting it onto our McFarland individual pages. My other partners in GI do it. I can tell you in the bigger market, when I trade in Tulsa, it was a selling point for the private practice doctors who were competing against employed doctors through the hospital system. And they would put their data out there all the time because they were trying to recruit business. I think it should be, it's just not required though.
Okay.
I have another question. If you've had colon surgery and then say a year later, would there be any gastrointestinal cramping that would be symptomatic that you should be concerned about?
It's hard to say. And I say that, oh, sure. So the question was if you had colon cancer and had surgery and you had some GI complaints, or something to be concerned about?
Yeah, but there would be some GI things going on that would cause the cramping besides colon cancer?
Oh, for sure. There's a litany of things that can cause abdominal cramps.
Oh.
So it's not necessarily that colon cancer came back where you have colon cancer.
Yeah, got it.
Left-sided colon cancers are more common with constipation and rectal bleeding. Because like you saw that colon cancer lesion, it gets bloody, and if it's on the left side, it can obstruct. Those symptoms never happen on the right colon because they don't block you. Things get across just fine. So there's less symptoms with the right colon cancer. So it's hard to say that. Sometimes when they take if you have your colons on the right side, they took that colon off, that part, when they do that and they rehook you up, they are taking away the brake system. And so you get more of your small bowel juices dumping into your colon faster, and your colon isn't used to that. It can get kind of bloaty or crampy, or you get diarrhea even. And it takes time to kind of regulate that after surgery. That's all kind of normal, but it's hard to say. And if it's continued or changing any factor, you definitely need to talk to the doctor about further workup of what it could be or other, yeah.
I assume the risk of perforating the colon with a colonoscopy is very low. What is the risk? What is the incidence?
Sure. So he asked about what the risk of perforation or percentage of perforation. It's about about 2,000 patients. 1 in 2,000 patients. And it's 1 in 23 colon cancer risk in your lifetime. So just to compare those numbers, right?
How long have you been practicing?
Here, 3 years.
3 years, but in total?
7 years.
So do you have a clue how many colonoscopies you've done?
Last year I did 1,500.
Oh, gosh. Okay. All right.
Yeah, that's about it.
A few.
Yeah. So,
What about irritable bowel syndrome
Sure.
and either constipation or diarrhea and its influence on?
colon cancer? Sure. So the question was, is irritable bowel syndrome either diarrhea type or constipation type, and its association or risk of colon cancer, which is 0. So multiple studies have been looked at that, and no increased risk whatsoever with irritable bowel syndrome, either type in colon cancer. Same thing goes with chronic constipation. So not even if you have irritable bowel syndrome, if you're chronically constipated, there's no increased risk of increased risk of colon cancer.
So I have a question.
Sure.
So colon cancer and rectal cancer, are they two different cancers or are they just polyps in a different place?
So the question is colon cancer and rectal cancer different? Yes. And I say that is because they're two different kind of organs that are connected. So colon cancer is predominantly treated with surgery and maybe chemotherapy. Rectal cancers are chemo, radiation, and surgery. Because everything down there is closer. So if it were to spread to go from that stage 1 to 2 to 3, there's a lot of things closer in your pelvis where the rectum is, and so it needs other therapies.
So are they detected in a colonoscopy then?
Yeah, we look at your whole colon from the start, the cecum, all the way back, and we actually turn around in your rectum to make sure we don't miss, because we're kind of walking into the room, you kind of miss the door, so you got to turn around.
You kind of think of it in the same process, but
Yeah.
when you talk about it, you talk two different things, and so I kind of get confused sometimes.
So yeah, and that comes from the medicine side. We call it colorectal cancer because it is the continuation, but we manage in the prognosis. Rectal cancer isn't as good. I mean, they really aren't. You're more likely to get a bag. There's risk of progression and metastasis at a smaller, because that closer knit organs there. So it does. If you look at its numbers, it's a completely different kind of ballgame. But it lumps together when we talk about it because it gets tested the same way. You screen the same way. We don't want you to get rectal cancer, just like we don't want you to get colon cancer.
Sure, yeah.
But it's the same. And we use those terms like I say colon cancer, but yeah, that could be in your rectum. But when it comes to treatment, they want to know if it's in your rectum or it's in your transverse colon. It really changes how you get treated, what we can offer you toolkit-wise, like what's in our toolkit to help you.
How do you like the new surgical center?
The question is, how do I like the surgical center? I love it. And I was the one that helped get it up and running. And I say that as I did 10 cases for free to be able to produce our kit or our little packet to send off to Medicare. And I've been doing cases all this month. So
At the new center.
at the new center, yep. But currently we only have privilege to do 2 insurances. So it's not widely available yet. We're trying, but this is how it works. You get your Medicare number, then we have to go out to all the insurance and say, hey, we have Medicare now. What are you going to help us get contracts so we can bill everybody's insurance? Right now we have Wellmark, so Blue Cross Blue Shield, and Medicare only. We are working on all the rest, but it'll be a staged process, so. Yeah.
I'm not sure if I'm understanding this. If I up my fiber, will that cut down on my polyps? Or am I just wishing?
So the question is, if I increase my fiber, will I have a reduction in risk of colon polyps and colon cancer? Yes.
It will?
There is, I mean, will it? No, I can't tell you that. Nothing in medicine is 100%. Sorry. But no, I mean, if you want to look at the data, yeah.
Okay.
Like I said, I don't have the graph because it doesn't pertain to us because this is talk about US, right? But there's a graph that you can look up of cancer in the whole world, and we're red and they're white. Red is bad, white is good, right? Like low numbers. Africa is all white. Sub-Saharan, like India and those areas are white. They're increasing because we are taking our Western diet and we are transporting it across the world and have been doing so since the 80s, right? McDonald's, Coke. So they are seeing upticks in their areas, but it's because of us, not them. They did native diets. They don't have the risks that we do. Now you compare that to upper GI cancers, which is not this talk. If you look in Africa or Asia, like Asia, so like India, and then you go into Asia, so China, Japan, Korea, that whole peninsula, they have a marked increase of upper GI cancers, and they screen people, all their patients for upper GI cancers and less for colon cancer. Because they have a much higher risk of upper GI cancers than we do. We don't screen people unless you're at high risk. It's a whole other talk. We talked about my GERD one 2 years ago, but it's a whole other thing. But so, I mean, that's what I'm saying. There's differences in our diet and our things. So can I tell you that you increase your fiber, you will reduce your risk of polyps? I can't tell you 100%, but there's data to say that will happen, right? It does reduce your risk. Yeah.
How common is cancer in the small intestine?
So the question is what's the risk, or what's the percentage or incidence of colon cancer, or sorry, small bowel cancer? Low, like low. Less than 2%.
Why is that?
Because we don't have a lot of diseases, luckily, that happen in the small bowel, right? So to bring up the inflammatory bowel disease thing, which is an autoimmune disease where you attack your own body or your GI tract, right? Like rheumatoid is your joints, lupus can be joints and skin and kidneys, psoriasis is your skin, right? Because those organs don't get affected as much, they don't have that turnover as fast, right? They're not getting beat up all the time. That can increase it, but no, small bowel cancers are exceedingly rare, which is good because you can live without your colon. You've heard people get their colon cut out, right? They get part of it removed. You can live without that. Once you start whittling on your small bowel, because that's where you absorb all your nutrients, you get too short, you can't live that way. You can't eat and survive. You have to do other stuff to get nutrients. It's called short gut syndrome. So good news, we don't have a lot of people cutting on or having cancer there. So that's just another kind of aside, but no, it's very, very low. Low enough that we don't actually screen anybody for small bowel cancer. There's no testing you should do. There's no PET scans or CT scans or other things we should do to look in for small bowel cancer. It's exceedingly rare.
HPV increased risk of colon cancer?
So the question is, does HPV increase risk of colon cancer? No. Rectal cancer, yes.
So I'm wondering, so we've heard lots of great reasons why to have a colonoscopy. We sat through a whole presentation. And I know, and I'm guessing all of you may know somebody who won't get one. So what would your elevator speech for us to say why you should get one?
So I would even go a step further back and just tell them they need to screen for colon cancer.
Okay.
So I don't care if they do a colonoscopy.
Sure.
I do them, but I would never tell anybody that they have to do one. I order Cologuards on people that don't want to do colonoscopies if I'm seeing it for other reasons.
Right.
Hey, you're due for colon cancer screening. I do colonoscopies, I can explain it, the risk of it, and I talk about their tests. And some people, they decide, I don't want to do that, I'll do a Cologuard.
Okay.
But
So,
I also tell them that if that's positive, you have to have a colonoscopy, you know that, right? So you want to cut out the middleman. But again, that's a conversation back and forth, so.
But that's a good point to be able to make to people. There is there's a non-invasive option.
Correct. And there's more and more of those, and that's the reason why, because there are, like I said, I showed you that thing, that 57% of people would rather do chores or their taxes than get a colonoscopy. So we have to have other options that are available for you in your lifestyle, what you're willing to do, what you're not willing to do, right? Not everybody can take a day off of work or prep for a day, because it is. 48 hours of your life are changed when you do a colonoscopy. We change your diet, you got to prep, you don't get good sleep, then you're sedated, and so those medicines wear off, take the day to wear off, if not longer, and so it does change your day. 2 days roughly. So
I think the prep's much easier than it used to be though, and that makes a big difference, because way back when it was like, ugh, but the last time it was prep, but it wasn't near like it used to be.
I didn't really go into that because that's not really pertains, but yeah, so the question was, our talk was about prep got better, and that is true. So we have gone, there's a lot more available, what we call small volume preps. You average about 3 liters over your total prep versus 4.5 liters typically. That's the difference. And then now they actually have pills. You can just take pills to do it. Caveat to that is they're expensive and your insurance doesn't always pay for them, right? Insurances love to pick the cheapest one and you get the cheapest one. But I can tell you, I predominantly do what's called Suprep. I have no money to the company. I'm just telling you the drug. But it's a low volume prep. It's covered by almost every insurance in our market, and it's $0 to you. So you just drink about this much of laxative, and then you drink water to help flush it. You drink another thing of this for laxative in the morning, and you drink a water to flush it, and that's it.
Yeah.
But it's a little more potent, so some people get a little more nausea. But just do your best. That's all I can ask for. You just do your best, and we'll do the rest. But you got to drink the prep so we can be helpful. The whole reason you do the exam. So.
Any other questions? No, lots of great questions, lots of great discussion. Thank you, Dr. Johnston, for your presentation and taking time out of your busy day. Yes. I just want to remind you, our next program is Wednesday, April 9th, and that is on fall risk reduction continuum. So we have a couple physical therapists that are going to talk about the risk screenings and high-tech therapy for those that may be at an increased risk for fall. We're also doing Wednesday, April 23rd, individual fall risk screening, so you can know what your risk level is, and they'll also give you options on exercises and groups and different things you can do to help reduce your risk for fall. And just so you all know, our AARP Smart Driver course, the end of April, is full already. So if anybody was thinking about that, we could maybe put you on a wait list, but it is full. So please fill out your evaluations. Give us ideas for other topics or presenters you'd like to hear from. Once again, thank you, Dr. Johnston. Great program, and everybody enjoy this beautiful day.
Thank you.